Finding answers to clinical questions can be daunting if you don't have a plan on how to access the evidence. Here I'll describe the Haynes 6S approach to finding high-quality evidence. This is a reminder of the 5 steps of practicing evidence-based medicine. This session will focus on the acquire step of EBM. There are 2 general types of clinical questions, background questions and foreground questions. Background questions ask very general information about a disease. For example, what causes congestive heart failure? It also asks information about the basic epidemiology, basic history and physical exam elements. In general, how is a diagnosis of this disease made? In general, what treatment can be used to treat this disease? But it doesn't ask very specific information that's going to be overly useful for any individual patient. In contrast, foreground questions ask much higher order questions about very specific therapies or diagnostic tests in the individual patient sitting in front of you. So for example, a foreground question might be, in a patient with congestive heart failure on optimal medical therapy, would implanting an AICD improve mortality compared to standard therapy alone? It's a very specific, much higher level question than this general information like in the background question. Information that we might seek might be about common medical disorders or rare medical disorders. Traditional medical textbooks are very good for background information, but not really much else. They have no method section, so there's no way of really telling how up-to-date the information is in the individual chapters. The authors tell us nothing about when they search for information, how any search was done, how they decided what to include or not to include in the chapter. And thus they're very limited references, so you can't really tell how evidence-based versus opinion-based the information is. Most traditional medical textbooks will also be out of date at the time that you get them. It takes time for the chapters to be written, to be edited, for the books to be printed, bound, and shipped out to the bookstores. So even if you get the latest medical textbook, the day it hits the bookshelf, it's going to be anywhere from 6 months to a year already out of date. For things that we encounter rarely, for which we have very specific questions, we're going to have to do a MEDLINE search and look for individual clinical articles. So what's the alternative to traditional textbooks for things we see commonly for which we have very specific questions? It's the filtered or pre-appraised literature. This is the Haynes 6S levels of organization of evidence. And the reason it's called 6S is because each of the levels begins with an S. One of the basic tenets of this approach to finding evidence is that we always start at the top and we work our way down toward the bottom. And the reason we always start at the top and work our way down is because the usefulness and the quality of evidence is highest at the top and decreases as we go down this hierarchy. You can also see this dotted line. The 5 evidence resources that are above this dotted line are called the pre-appraised research. The reason they're called the pre-appraised research is because someone else has read them and critically appraised them for their methodological quality and determined that they're scientifically sound. Below this dotted line are the individual studies or the primary original research, and this is where we have to do a lot of work. Number 1, to find these takes a lot of work, usually doing a MEDLINE search. And number 2, once we get studies, we have to critically appraise them and make sure that they're scientifically sound. We do not want to be misled by a biased study. So let's look at each of these individual S's. Again, we're going to start at the top, work our way down. So what are systems? Systems are clinical decision support systems. What they do is integrate research evidence with individual patients' information, usually through an electronic medical records system. They recommend what could be done for the specific patient sitting in front of us. It knows what your patient's problems are, their medications, lab results, etc., and make very specific recommendations for that individual patient. Now, a lot of hospitals and clinic systems already have electronic medical records, but the limitation at this current time is that a lot of information resources have not yet been integrated with these electronic medical records, but that's coming in the very near future. Where I work at the VA, we have a rudimentary example of a clinical decision support system. This is a screenshot of our electronic medical record for one of our patients who has diabetes and hypertension. And the system will look at these diagnoses. It will look at the patient's age. We'll look at the vitals, look at his labs, look at imaging things, etc., and make specific recommendations to improve the quality of care of this particular patient. So I mentioned this patient's diabetic, and in clinic today his blood pressure is 151/72. Well, the system knows that in a diabetic the blood pressure is recommended to be less than 130/80, so it gives me a warning that this patient's blood pressure is too high. It also searched throughout the system and noticed that I hadn't done a diabetic foot exam in the last year, so it gives me a warning to do a diabetic foot exam. Now, what I'd like to see, besides just telling me I should do something, is tell me why I should do something. So the next step that I hope to see in these kinds of systems is that they won't just tell me that I need to do a diabetic foot exam, but they'll tell me why and give me links to the evidence supporting these recommendations. It might be a clinical practice guideline, it might be the individual studies, but I'd have some link if I care to look to say what this recommendation is based on. So we're not quite there yet, but that's what the future for evidence integration into electronic medical records will look like. So if I can't find an answer in my clinical decision support system, or I don't have access to one, I move down the hierarchy now to summaries. And summaries are of two flavors: clinical practice guidelines and evidence-based textbooks. I'm not going to talk much more about clinical practice guidelines because I'll have a session on that later in the course. And we'll talk about evidence-based textbooks in a little bit more detail. And the way I know something is an evidence-based textbook is that it has a methods section. It has very explicit methodology of how the information in the textbook was developed. It's also regularly updated, and the recommendations that are in it are graded based on the quality of the evidence and supported very clearly with references. And in most evidence-based textbooks, if you click on the references, you also get either a full text article or definitely a MEDLINE link to that particular reference. So very different than our traditional medical textbooks. If I have no answer to my question in either a clinical practice guideline or an evidence-based textbook, I move down the hierarchy now to synopses of syntheses. And what synopses are very structured summaries of high-quality studies. In this case, this is a structured summary of a high-quality systematic review, because syntheses are systematic reviews. So if I've worked my way down to a systematic review and I still can't answer my question, I'm going to move next to synopses of studies. And again, this is a high-quality structured summary of an individual study. Not all studies are going to have synopses of them because not all studies are high quality. So you're not going to find a synopsis of a study for every study that's published out there. You're only going to find it for ones that are of high methodologic quality and of clinical importance. And finally, if I can't find an answer in any of my pre-appraised resources, I'm going to have to now go down to the very final rung of individual studies. And these are usually located by doing a MEDLINE search. And this bottom rung requires the most work because I have to critically appraise these studies and make sure they're good. And also the time required to often search for them using MEDLINE can be a little bit longer than we'd like, and definitely much longer than finding information higher up in the hierarchy. This shows examples of products that are each of the individual S's. We're not going to talk about clinical decision support systems or practice guidelines, but these are a variety of evidence-based textbooks that are out there on the market. The two most commonly used are going to be UpToDate and Dynamed. In my opinion, Dynamed is the best product out there. There's a study supporting how UpToDate Dynamed is published in the British Medical Journal. So for me, I think this is the best quality product that's out there. The really nice thing about evidence-based textbooks currently is that a lot of our clinical questions can be answered up here, so we can stay very high in the hierarchy with high usefulness and low work and answer a lot of our questions. ACP Journal Club publishes synopses, both synopses of syntheses and synopses of individual studies. ACP Journal Club is produced by the American College of Physicians via the Annals of Internal Medicine. There's some other journals that are similar to ACP Journal Club. One published by the BMJ called Evidence-Based Medicine also publishes synopses. So these are a great resource, and I use ACP Journal Club a lot just as a method of keeping up, because each edition may have 10 or 15 articles in it. I can keep up and read that every time it comes out. I can't keep up with the hundreds and thousands of journal articles that are published each week. So ACP Journal Club for me is a great way to keep up with the medical literature. Systematic reviews are published in a variety of individual journals, but there is one database dedicated to systematic reviews, and it's the Cochrane Database of Systematic Reviews. These reviews are developed by the world's experts in doing systematic reviews. You can trust them directly and not have to think about using them very much. The limitations of the Cochrane systematic reviews is that there's not going to be a systematic review on everything, and because they take so long to be developed, they tend to get a little bit out of date just because of that time it requires to do them right. And finally, I mentioned earlier about MEDLINE to find individual articles. One place you could look to begin with to try to find answers across a variety of these resources using this meta search engine called the TRIP database. If you put in a term, let's say congestive heart failure, the TRIP database will search across a variety of resources to present to you individual articles, clinical practice guidelines, systematic reviews, synopses, etc. The only thing it really doesn't search are evidence-based textbooks, so that you'll have to look in yourself. So finally, you're going to develop lots of questions during the course of each individual day. How will you decide which ones to answer? This is my individual approach of deciding which question I'm going to answer of the multitude that come up each day. One of the best approaches, I think, is to think about how much time do you have available to do a search and answering the questions that are best for your patient's outcomes. I think those clearly are the two most pressing things that help us decide which questions to answer. And finally, even though I put it down at the bottom, I would really spend time on things you're going to see very commonly, because this will be a wise investment in your time.